So, as far as depression being a barrier, when a person's depressed, first of all, they feel sluggish, often low energy, low motivation. They have problems concentrating. They get easily overwhelmed. And frankly, a lot of times they're just saying, what's the use? What's the use? Their motivation just goes out the window. And sometimes depressed people even have suicidal thoughts, or they're just, maybe passively suicidal, and they're just thinking, why do I even need to take these medications? I don't even feel like living. So just thinking about that at a clinical level, that's a huge barrier to people taking any kind of treatment. And so what we know from our studies is that when we looked at depressed people at Group Health Cooperative, for example, who were in the top tertile of depression compared to the bottom tertile, the difference was double. 14% had lapses in their medications if we looked at pharmacy data compared to 7%. In another study that we did, we looked at lipid-lowering agents, and about 50% more people that were depressed, so amongst people that were depressed, they had 50% more non-adherence. Amongst people with taking ACE inhibitors, there were 33% more likely to be non-adherent if they were depressed. So we've shown this over and over, and any clinician would say, yeah, no kidding, depression gets in the way. It just is a real, at every level it potentially affects a patient. And that's why we need to really aggressively treat depression. But what we've discovered also in our trials is it's not enough just to treat depression to get better outcomes. You also have to handhold and help patients be convinced again and improve their motivation once the depression starts to go away, to get them to start taking the medications again.